Hi everybody, my name is Rhys Barber. I'm one of the audiologists here at Audiology Associates.
And my name is Taylor Green and I'm the other audiologist here.
So we got a good one today, guys. This is actually a mastoid cavity clearance. And this is super, look at that. What's that, Taylor Green?
That is probably one of my favourite tools.
It was cheated on you, Taylor. It came and worked with me for the day. But this was a mastoid cavity, super dry. And this is literally rock solid, right down on top of the eardrum. You can see just how tough this is. So this patient has appeared on the channel before. Last time we did this, I think the video was like nearly 20 minutes long. There was a lot of skin to clear out. You can actually see the mastoid cavity. So if you're new to the channel, you don't know what this patient's had a mastoidectomy. The mastoid bone, if you tap the bone behind your ear, that's your mastoid bone. So what happens is a lot of the time it's like a honeycomb structure. If somebody's suffering with ear infections a lot, so the middle ear infections, you can pass that into that structure and it's very difficult to treat. So a lot of the time, not a lot of the time, but sometimes in very extreme cases, they will actually remove that bone. Yeah. You can't remove the entire bone because you have to leave what they call a shelf, which is what you can see here, because you have some quite important nerves which deal with facial movement and hearing. They pass through this little space in that area. So you've got to keep that shelf there so you don't run anywhere near it. But this particular patient was a tough one. This wax is so dry.
Solid.
And it's right down on top of the eardrum as well. We've also actually got to clear the cavity, which is to the top right. So what you're looking at the bottom of the screen, that's the eardrum. So imagine that would normally be the whole of the size of the ear canal. And then you've got this shelf running over the top, which is an absolute, a chunky old shelf as well up there. Yeah.
That is rock hard.
You can see I'm trying to get a grip. I thought, well, perhaps, not quite as pointy there for the Rosen insert. I might be able just to get a grip on the side, but you can see just how tough that is, Taylor.
No, that's not going anywhere, is it? Oh,
yeah.
Hang on. Oh, I thought that whole thing was moving.
I thought the whole thing was going to go then, but it just broke a little bit off the edge. So I'm just tidying up these parts. With this particular patient, and with a lot of mastoid cavity patients, suction tends to trigger off a bit of a dizzy reflex. It tends to kind of really cause a lot of dizziness in these particular patients. That's just due to temperature inside. It's called the caloric effect, so it's due to temperature inside the ear canal. Yeah. So we try not to use suction as much as we can on these patients. Sometimes you don't have a choice, but we do try and do it. Look how flaky that is.
I know we do have a patient in our Cardiff clinic that regularly attends, and it's impossible to get there with manual tools.
Yeah.
You have to use suction.
That is a deep bone.
Oh, it's very deep bone. It's very high as well. Yeah. It's right up in the corner.
And he's felt dizzy a couple of times, doing it.
Pretty much every time.
Yeah.
Yeah.
So we just
kind of expects it now every time he comes in. So it's a tricky one.
Because that's all you got to do is just take a break and just allow the temperature to come back up in the canal, and everything feels a lot better. So I really thought this is going to be such a long process because it's only coming away in very, very thin layers. And then I get a little hook in, not quite there. You can see I was almost got a grip then. Now I'm conscious that the eardrum is behind this.
Yeah.
I'm just trying, there's a little ledge there, and you can see me just trying to exploit it, but it's that hard to try and push into the ledge. You can see it's flicking off. But I'm trying to get to this little part of the ledge. So I'm looking now to see, you can see me kind of weighing up, well, do I go left, do I go right, do I go at the top?
Ooh, look at that.
Yeah.
Oh, here it comes. Oh.
You can see that starting to go there, and I thought, oh, okay, well, now it's going to pull this kind of top section forward a little bit. See if I can drop into this again now. Oh, not quite. Yeah, I do apologise, because sometimes it's flicking off. It'll flick over and just catch the opposing canal wall. There we go.
Oh, that's it. I was literally just going to say you're going to squeeze down into that little gap there. Not squeeze, but you know what I mean. Just
well, look at this, peel it away.
Whoa.
And there you go, there's the eardrum beyond. So you can see how this is built up, that really soft, fresh skin layer underneath. So instead of migrating out, which is also a common problem when you get mastoid cavities like this, the skin tries to migrate out, but it kind of has a lot further to go because it has to go into the cavity and back out. So yeah, real kind of, in this one, it's almost building up in situ. It's kind of building up as layers on top of the eardrum.
And I've seen a couple of comments in the past saying, oh, why didn't you do more mastoid cavities, but we can only do what comes into clinic.
Yeah, we'd love to show more, but you just kind of, a lot of the time, and the other reason is because a lot of the patients who've had mastoid cavities, whether mastoidectomy, normally they get seen on a regular basis by ENT, so they're actually under the hospital anyway. So I've cleared the blockage at the eardrum, but you can see now that shelf at the top, and you'll really see there's a lot of skin up in that shelf that needs to come away as well. So that's our next job. This actually came away a lot better than it did last time. It was a real kind of beastie last time to take away.
I think I've actually seen this patient myself.
Yeah.
Yeah, I think the very first time he came to us, actually, I think was when I first saw him, and it was front to back.
Yeah.
I mean, completely full.
We do always advise patients you'll come back in.
Oh yeah.
6 months, 12 months, whatever it is. But yeah, this one, really struggled. I did actually have a lady this morning. Well, last time we took it out, oh my goodness, she had to tell the practitioner to stop because it was causing so much pain in her ears. And she went back for a follow-up and exactly the same thing. Yeah. And we got it out, completely pain-free. And I advised her to come back in at 12 months. In fairness, she did this morning, so it was really good. Yeah, much nicer. Look at this thick layer of skin. Yeah, I was really hoping this was going to turn into a skin ribbon. And I was kind of like, oh, is it? And it wasn't. It was just a peeling of all that surface layer of dead skin. Look at this. Watch just above the crocodile forceps. You'll see it all peeling the entire length.
Oh, that's perfect.
Of the cavity.
Oh, but that is the best one that he's had with us so far.
Look at that. I completely cleared that entire cavity. That's the cavity we're looking at there. There you go. Looking good. There is a completely
normal looking eardrum.
Yeah. And then we just take this thought I'd try with this last bit. I'm only going to do a little bit of suction. If it's not going to come, it's not going to come, which it didn't. It was still holding on tight. I'd rather do that than try and try and suction everything, but I just had a good old look. There you go, cavity looking good. So this was actually the other ear, very similar in consistency, but no mastoid cavity on this side. Okay, this is just standard ear canal here, but still super duper dry.
Oh, it's just got the type of wax you don't need for that type of problem.
It's almost got, we had one the other day, didn't we? We said about that, someone was saying, was it a fungal infection? But you get it when the wax just goes super dry like this. It's almost like this white kind of dusty sort of coating over the wax, isn't there? Like as if somebody's put like caster sugar over the top, not caster sugar, icing sugar over the top of it.
I can see a bit of it there.
It's just so dry. So this is the rye hook going in here. There we go. We're just going to take the next section. Now this bit here, I was like, oh, okay, it's super hard. It's really thin, so maybe I'll be able to kind of started off by trying to lift the back forwards, and I thought I'll try and lift the front. That's just not going anywhere.
Solid.
It's literally just clicking and just jumping off the top. Yeah, it's a beastie, isn't it?
Yep.
So I thought, I'll try and get behind it and pull it forwards using the rye hook. But it's just so thin. I can't even get the rye hook to get behind. It's just clicking off the top.
Oh, that's a bit of a pain.
Yeah, not an easy one to get out. You can see I'm trying to move these kind of looser bits just to get that little bit of a hook behind the last end. But I thought, do you know what? I'm going to try and use the Rosen inserter a different way. I'm going to turn him upside down and use him as a lift.
Yeah, I've done that a couple of times.
Yeah.
Usually looks pretty good, to be fair.
Yeah, it's come away nicely. As long as you're only hooking it into the piece you've just peeled away, you're not going to be hitting the canal wall as well. There we go. And then
crocodile forceps.
Forceps now should go in. Yeah, there you go.
Oh.
Yeah, he's awkward because that front section keeps folding in on itself.
There you go.
Lovely. Really, really nicely that one came away. That wasn't really causing any issues, and patient does have reduced hearing on the other side anyway from the op and the scarring.
Yep.
Last little bit of dry, you can see stuck to the roof of the canal. It's just hidden behind some of these hairs.
Come on.
I know, I just want this last bit just to shift now.
That's a good job though. It was a job well done.
I was surprised that came away as well as it did mine, I've got to be honest. Looking at that bit on the left, I'm going, is that got a clarinet? Can I get that away without it squeaking like Billy O? But it's just so dry in here.
Yeah.
There we go. I do try and lift this bottom bit, but it's quite firmly kind of anchored on. And there's a little weird little plate just here to the right hand side, so we just lift that up. There you go. And I'm like, oh no, we've got another peel going on now.
Oh,
look at that.
Nice.
Looking nice. So that's nice and clean on both sides, very different, you can see on that one.
Yeah.
And that's where you move. So the piece you can see from 0 to 2, that was actually the whole the cavity skin.
Yeah.
Yeah, and then the chunk around about the 1.25 to 3 centimeters mark, that's the plug, and then the remainder is what came out the other ear.
Yes, we're 4 3/4 centimeters.
Yeah, 2 inches of skin there, mostly, rather than wax and skin. Well, guys, that was a good one. I told you it was a good one, didn't I, guys? Well, guys, if you do enjoy that video, you can always like, heart, share, follow, and subscribe for me. If you really enjoy the videos, you can also consider becoming members of the channel. If you check out the link in the link tree in the description, there should be a link to take you to become members of the channel as well. So you can take a look at that. And you get 2 more videos every single week of Wax Mobile, like yesterday's video and tomorrow's video. But as always, guys, take care of yourselves.
Take care of your ears.
And take care of one that I messed it up with Katie.
Oh, did you?
I said take care of your ears first. I don't know why. I never say take care of your ears. Every single time me and her do a video, I can't get it right.
That's why I don't even bother to film it.
And we'll see you for the next video.
Thanks, guys.
Bye.
Bye.
Everybody.